So I've got that recording started. What you see on your screen right now is the CME credit information. So this EPIC breastfeeding training webinar today is designed to improve breastfeeding care practices through education for physicians and staff. It's a physician training process modeled after successful programs in other states. And this will give you the knowledge needed to train your staff, colleagues, and other community partners. At the conclusion of this program, you should be able to recognize the importance of breastfeeding for the baby, mother, and society, review evidence-based policies and practices, review management of common breastfeeding problems, identify how to set up a breastfeeding-friendly medical practice, and how to utilize community support. After the webinar today, you'll be receiving information about CME credit. And our next slide here is our accreditation statement, designation statement, and disclosures. So our presenter today has nothing to disclose. No commercial support was received for this activity. With that, I do do one other housekeeping thing. You should have a chat function so you can ask questions during the presentation, and we may wait and hold those questions till the end. But that is the way, through the Q&A button, is how we will do our Q&A at the end of the session today.
And hello, my name is Tina Cardarelli, and I'm the State Breastfeeding Coordinator, and I would like to introduce our speaker for today. I'm really excited about this speaker. Her name is Dr. Mandy Dornfield, and she has been practicing family medicine for 10 years in Columbus, Indiana. She and her partners care for infants through adults and provide obstetrical care. Dr. Dornfield helped found the Bartholomew County Breastfeeding Coalition and served as its chair for several years. She received her certification as a board-certified lactation consultant in 2011 and offers breastfeeding medicine consults in her office. Dr. Dornfield currently serves as Chief of Staff at Columbus Regional Hospital, which is proudly a baby-friendly hospital. Mandy and her husband, David, have 3 kids, ages 10, 7, and 5, and are currently hosting their second exchange high school student, 16-year-old Sophie. I also would like to recognize that Dr. Dornfield was our first recipient a couple of years ago of our statewide breastfeeding award of excellence as Physician of the Year for breastfeeding. With that said, I look forward to learning from Dr. Dornfield, and I'll hand it over to you, Dr. Dornfield.
Thank you very much, and thank you for having me. Let me pull up my slides and we'll get going here. All right. Well, thank you everyone for giving up your lunch hour to come and share this discussion. Obviously, it's something I'm passionate about, and I think that it's really important for all of our patients that we are well versed in breastfeeding. Basically, it's important to know that women make their feeding decisions early in the pregnancy, and it's also important to know the power that we have as physicians to influence a woman's feeding choice. We know that if a physician recommends breastfeeding, she is much more likely to consider breastfeeding for this pregnancy, or maybe in another pregnancy in the future. I think that we all feel the barriers to this sort of discussion. Time is always the limiting factor. Obstetric visits, we barely have any time, where our nurses are doing the urine, the blood pressure, we come in, do our part, and it feels like it's just another added thing to talk about. Our visits are short, and quite honestly, I know I wasn't adequately prepared to talk about breastfeeding and educate about breastfeeding when I first left my residency. I think sometimes I know I have secretly hoped that no one asks me questions, at least in the past, because they take time and we don't always know the answers. That's not a good feeling. And then, of course, none of us want anyone to feel guilty about their feeding choice. That's her choice, and that's not what this is about. It's about empowering a woman to make an informed decision that's best for her and her family. The most important thing is that she has adequate information to make an educated decision. Patients can't make that educated decision without understanding the benefits of breastfeeding. There's so much evidence now. At one point, we didn't have evidence-based medicine for breastfeeding, and now we do. There are several scientific journals now with hundreds of articles a month. So we know now that there are true benefits for mom and baby, and I think it's important for women to know that. It's important for us to know and accept not everyone will breastfeed. That's okay. Some barriers are just too hard to overcome, whether that's going back to work way too soon, no place to express milk despite the laws. But introducing this information now, that may kind of stick in the back of her head, and then maybe the next time she may make a decision to breastfeed if her circumstances have changed, and that's okay. In my practice, I see really all kinds of patients. I see a fair amount of Medicaid and underserved patients. I see women who have breastfed. I see women who've never had a friend or family member who breastfed ever. So I try to start with an open-ended question, and I think that that's a good way to do it. I say, have you considered breastfeeding? And that way they can tell me, yeah, I've considered it, but I don't want to do it. Or, yeah, I've considered it, I'd like to do it, but I'm afraid it's not going to work out for me. Or if it'll work, I hear a lot, well, I've considered it, I'd like to breastfeed if it will work. But it allows her to express any concerns she has at the same time. I think it's really important to address this at the very first visit. Breastfeeding, to have a successful breastfeeding relationship, she needs to know, really have time to be educated about breastfeeding, and also it allows her time to consider her options. I try to assess pretty early on if there's a support system that she has, and I'll ask, do you have any family or friends who have breastfed? She's a lot more likely to be successful if she has a role model in her circle, who she can talk to, ask questions to, or she's seen someone do it successfully. So I think identifying those cheerleaders early is really important. What if she says, yeah, I thought about breastfeeding and I don't want to breastfeed? That's okay. Our job is to make sure that we educate and respect that decision. A lot of times I might ask, what helped made her decide not to breastfeed, or what influenced her decision. Just so I have an understanding of the obstacles and her challenges. So many moms are single moms or moms who are working and have little kids, and there are a lot of challenges out there, and that just helps me to understand more what they're going through. Or maybe she breastfed before and it didn't work, or maybe it was painful, and some of those things we can work on. I do make sure that women know it's not all or nothing. Some women breastfeed a week or 2 weeks or 3 weeks, and I am always careful to celebrate that's a week of breast milk that you were able to give, or 2 weeks, or whatever that may be, and what a great job you did, because for them, that's what they can do, and you meet them where they are. So certainly no one should be considered a failure if she didn't breastfeed longer. And even if that's her plan, if her plan is to breastfeed for 2 weeks before weaning to formula, then let's help her to accomplish those 2 weeks, because that's 2 weeks of bonding and antibodies and breast milk that baby wouldn't have gotten otherwise. So I really try to take that approach. So I guess in talking about this, I just want people to know that there doesn't have to be a guilt thing. Celebrating women where they are and whatever success they have can be empowering for women. And starting this conversation at the beginning of the pregnancy opens the door so we can continue 9 months of education. Common reasons for not breastfeeding, and I've heard all of these, and I'm sure you have too. I smoke, so I can't breastfeed. I'm going back to work. I don't want my breasts to hurt. I've heard it's hard. I've had a bad experience in the past. I take an antidepressant. None of these are are factual contraindications to breastfeeding. Now, it may be that it doesn't work out for her, but there's not a contraindication. So sometimes just educating of what is and isn't a contraindication can really be helpful. And also, if someone is going back to work and she would be open to expressing breast milk at work, you know, we could be a cheerleader or set her up with someone who can help her to set up that situation at work to be able to express, or maybe she just needs the words to be able to talk to her HR manager. And sometimes we can do that, or we can hook her up with someone who can help to do that with her. So there are some really simple things. You know, we're all kind of in this journey of taking care of breastfeeding moms, or moms who may breastfeed in a different place. And it doesn't always have to be a big, long discussion and education. There are some very, very small, easy steps that all of us can take in our office. And one thing would be to consider what our posters and gifts are saying to moms about formula. It's really important that we not market formula, because it gives the message, even if it's unsaid, that formula is just as good or maybe even better than breast milk. And we know this from studies. It's not just an opinion. There are really good studies showing that those unspoken marketing messages can affect a woman's choice about everything, or even, you know, for that matter, marketing cars and things like that too. Formula companies certainly would not be using these methods if it didn't work. So any visible branding of formula companies endorses and markets the formula. If you give out formula in your office, consider keeping it in a closet. And consider getting rid of any marketing or even if it's considered educational posters that have the formula title on there. So look at any posters. You know, were they given by the formula company? Don't give out gift bags. Don't give out gifts of formula. Those are really simple things. It doesn't cost us any money to do those things. And keeping formula maybe that's used for urgent situations, or a baby who needs formula in the office, just keeping it locked up is an option. In my office, you know, we see moms and babies. We're a family practice, and we, for years, had given out marketing materials. We had posters up, doing all those things. And when my eyes were kind of opened to the influence that can have on our patients, and I brought this up to my partners, I thought it would be a really big deal to get rid of that marketing stuff. And honestly, it was kind of a no big deal at all. We even talked about, well, we could buy formula and have it here in case there's a baby who needs formula, you know. But honestly, the sort of situation where a baby is going to need formula emergently is incredibly rare. And in those situations, usually the baby's going to be admitted to the hospital, and we can just get them over there just as quickly to get that taken care of. So it's really been a non-issue, and didn't end up being as big of a deal as I thought it would be. No one's ever complained. We've never had a patient complain about not getting free formula. There's some really simple things we can do when we're doing our normal exam anyway. You know, most of us do a breast exam at that first OB visit, and I think that's a time when you're doing the breast exam, you can say things like, you can expect your breasts will get larger through your pregnancy. That's your body preparing to be able to make milk for your baby. You can tell her that she may or may not see colostrum, or as she gets farther along in her pregnancy. I had someone tell me at about 36 weeks once that they were really disappointed they weren't going to get to breastfeed because she hadn't seen any milk. Certainly a lot of women do have colostrum and will notice some colostrum at the end of their pregnancy, but some don't, and that's okay. So that was an area where I was able to re-educate and reassure her that she would probably be able to breastfeed just fine. It's also a time to notice breast anatomy that may give her a challenge, or that she may think gives her a challenge. For example, inverted nipples, if that's normal for her and not new. We can reassure her that that doesn't mean she can't breastfeed. Sometimes we have to do some special things, but some women think, well, I'm not going to be able to breastfeed because my nipples are inverted. If a woman has a diagnosis of PCOS, there is definitely an association of PCOS and low milk supply. That doesn't mean we should set her up for failure and say, well, you're not going to be able to breastfeed. But it does mean we can kind of forewarn someone and say, some women with PCOS have trouble with milk supply. Because of that, we want to do everything we can to get you off on the right foot. And it's also, you know, the baby's doctor, you know, and the patient may need to know that, because if there's more weight loss than expected in those first week or so, we may want to intervene sooner with some supplementation if needed. If you expect a patient to have some challenges, consider referring prenatally to a lactation consultant. We don't have to know it all and fix it all and educate it all. You know, a big part of being a breastfeeding friendly physician is knowing where to refer and getting the help around your patient. And you certainly do not need to do it all yourself. If a patient has a history of insulin resistance or PCOS or a history of a breast reduction, or maybe breastfeeding didn't go well the first time, or inverted nipples, we could always have them see a lactation consultant during the pregnancy and kind of talk through some of those things and come up with a plan so that she feels empowered and comfortable and not totally overwhelmed if things don't go, you know, textbook after the baby is born. I will tell you that I have had some trouble getting lactation consultants covered by insurance. I finally figured out part of the problem here in my community is that a lot of our private practice lactation consultants are IBCLCs, but they're not necessarily nurses or licensed. And in our state, you require a professional license to have, you know, to be licensed, a professional degree, so like a nurse or dietitian, etc. And so unless a lactation consultant is licensed, we are finding that insurance will not reimburse those visits, despite the fact that they're very knowledgeable here. We do have lactation consultants through our hospital, but they really aren't staffed in our community for outpatient lactation support. They have a hard time getting them in. So just be aware of that. Know what support groups are in your community. We have Lactation League, which is a really great active group here in Columbus. We also have a drop-in support group that is run by a lactation consultant and supported with funds from our hospital that we call Nurse and Chat. And so referring to those groups can be really helpful ahead of time, so she knows where her helpers are and her cheerleaders. When I talk to a mom about breastfeeding, I put her decision clearly in the chart somewhere. For me, I put it in the problem list because I don't want to keep bashing her over the head with it. If she's decided no and it's a no, then I don't want to continue to discuss it. If it's, I don't really know, it didn't work last time, I'm not really sure, maybe not, that's different. And it tells me how to shape my conversation later in the pregnancy. And maybe at 28 weeks, I'll say, hey, with your birthing class, there's a breastfeeding class. I know you had trouble last time and you're still thinking about it. Maybe that would be a helpful class this time. But I want to be respectful of her decisions. And I certainly don't want to ask every single time, you know, that's not appropriate either. If a patient has chosen to breastfeed, there's some things I try to be sure to do. I have a little lending library of several books. One of them is called Dr. Jen's Guide to Breastfeeding. I don't know if you can see this. Dr. Jen Thomas is a pediatrician and IBCLC in Wisconsin. She has spoken several times here in Indiana, and she's written a really nice book, very accessible to patients. I think it's quite funny. But it kind of goes through the science behind breastfeeding and why it's so important and the benefits of it. I also think it's accessible because she tells her own story, and with her first child, she was not successful breastfeeding. She breastfed for a very short time, and I think it allows people to feel human and that it's okay. So I really like this book. I lend it out. I make sure that a mom is signed up for a breastfeeding class. if she hasn't breastfed before and she's interested. At the 36-week visit, that's when we do our GBS. So I feel like it's a good time to kind of sit down and say, okay, in a month you're having a baby, what concerns do you have? It's not a long discussion. I know you want to breastfeed. In a month you're having a baby, do you feel ready? If she doesn't, we don't have to do all of that. Some of that can be reassurance. It only takes a second. One sentence of, I know it's a scary feeling to be thinking about doing something you've never done before, but let me tell you, we have a great group of lactation consultants, and I know that we will help you to do your best, and your baby's going to be in good hands. Just talking up your team and giving her confidence can go a long way for her being successful when the baby is born. Also discussing a breast pump if needed. A lot of times your hospital may have a policy in place. Our hospital, if a mom plans to breastfeed, we have a plan in place that at her prepare visit, when she goes in to sign all of her paperwork, we also go ahead and get that ordered for her through her insurance. And that's been really helpful. If you're interested in learning how we do that, I'd be happy to talk with you offline. We use a mail away company, check insurance, and send it off, and it's cut down on the paperwork quite a bit. If a mom has chosen not to breastfeed, it's equally important to make note of the why, like we talked about. Sometimes further discussion is inappropriate, and sometimes she'll be open to more education. I think it's important that we understand what our classes have and don't have. Do your birthing classes include a breastfeeding class or not? Know what the breastfeeding classes include. And then we need to think outside the box for a lot of our patients, because a lot of them can't get to a class, unable to get to a class, she's working, transportation issues, whatever it may be. What other options are there? So in most of our counties have women, infant, children, WIC, and WIC usually has a lactation consultant and a peer counselor available. So getting them into WIC. WIC generally has breastfeeding classes. That's all free if they qualify for WIC. The other thing I think that really I've learned in the last couple of years is that social media and internet resources are becoming very important to our patients. You can go to YouTube and type in just about anything about breastfeeding, and you can have a demonstration right in front of you. So I actually do that with hand expression. I'll have moms go to YouTube, type in hand expression. I like Stanford University's videos because I know what they're going to show, and I know it's evidence-based. Pumping, all kinds of things, and they're right there at your fingertips, so it can be really helpful. Also, kellymom.com. It's a great evidence-based website that I know that my patients can trust anything that's on that website. It's published by a lactation consultant, and there's information on there about milk supply and protecting your supply, and the 4th trimester and the 2nd night, and how tough that can be, the fact that newborns want to breastfeed all the time. So again, it's knowing these resources and giving them to your patients so that you don't have to do all of that and do all the teaching in your office, but just being able to give your patients resources demonstrates how supportive you are. I think social media support groups have become very important, believe it or not. Most communities, or a lot of communities, will have a closed support group. In Columbus, Indiana, there's one called Columbus, Indiana Nursing Mothers. It's closed, which means someone has to request to be a part of the group, just so that they're sure to get people of similar interests and not people who really don't belong there. But it's a great way for moms to support moms. Granted, it's lay people who run the group, but feeling like you're not in it alone and you have someone to talk to about a problem, or just putting it out there at 2 o'clock in the morning if you're out breastfeeding, is tremendously helpful. And there have been a couple of studies that have shown that those social media support groups really improve breastfeeding success. At my 28-week visit, I don't know how you think about it, but at my 28-week visit with patients, that's when we do their gestational diabetes screen. So I kind of think of it as kind of a big visit. They're there anyway. They're doing their diabetes screen. We do their whooping cough shot. We give their Rogaine if they need it. And it reminds me to do a couple of other things. Number one, I talk about rooming in, and we talk about how important it is. In our hospital, when we became baby friendly, I thought the difficulty would be in getting rid of formula bags and all these other things. But the difficulty was in our staff feeling guilty about rooming in. And it really shouldn't be that way. There will always be babies that there are reasons that the baby needs to be taken out of the room. It's going to be the exception, not the rule. But maybe mom has twins and she's exhausted, or maybe mom had surgery, or maybe mom is on pain medicine and really it's unsafe for her to keep the baby in the room. That is okay. But for the typical mom-baby couplet, we find that it's really been a good thing once we learn the language to explain to the moms and babies and nurses of rooming in. So I try to use these sort of sentences. I say things like, unless your baby is sick or needs special care, your baby will stay with you in your room during your hospital stay. I always tell women it's very important to have a helper spend the night with you, someone who can help with the care of your infant. I personally say there's a reason why we're not supposed to have to do this alone. It's because it's really tough and almost impossible to do it alone. Everyone needs a helper. So that helper could be dad or a partner or a sister or a grandma or whoever it is, but no one should be caring for a baby on the first night all by themselves. The other thing is, at home, she'll need a partner. So this is a good time to teach that partner or helper infant care, infant cues, and things like that. So I also say our nurses will teach you how to care for your baby in your room. And it's an opportunity then to talk about breastfeeding questions too. So I have found that once we kind of moved to this language, everyone felt much more comfortable. I think it would be pretty unfair not to tell a mom that we do rooming in. We need to tell them ahead of time so they can prepare for that. I have some moms who've kind of been through it before and have 2 kids at home. They're like, oh, my husband's just going to go home, stay with the other 2. I really encourage them to reconsider that, because you never know how that night's going to be, and that sometimes even just having your loved one there with you to kind of say, it's okay, you're going to get through this, just as a support to you, not necessarily with baby care. So that allows us to talk a little bit about that. I also talk about skin to skin at that 28-week visit. I explain what it is, the benefits to mom and baby. We talk about bonding, temperature regulation. I tell them it's evidence-based and it's the best thing for you and your baby. We recommend skin to skin for all moms, even if they don't plan to breastfeed, that's fine. Occasionally moms will choose to breastfeed after baby's skin to skin, and if a baby self-latches and she's like, hey, that didn't hurt, this is fine, and that's a win. And it's good for mom and baby. Now, all of that thing that we just talked about at 28 weeks, it may sound like it was a lot of information, and how in the world can you talk about all of that at one visit, and it's going to take so much time. But quite honestly, I think that a couple of sentences can do it, and saying things like, you know, at our hospital, our babies room in with their moms because it's evidence-based, and we know that moms are better at taking care of their babies, and babies are better off being near their moms. We always want you to have a helper with you in the room, so consider if that's going to be dad or partner, boyfriend, sister, whomever. We always, after your baby's born, we dry the baby really well, and we'll put the baby skin to skin with you, because we know that's the healthiest and best place for you and your baby to be together. And that's it. If she has questions, we can answer them, but it's really pretty quick. And it's just a matter of getting in the habit of saying those things. And those 1 or 2 sentences coming from a physician make all the difference in her confidence and her decision to practice skin to skin or breastfeed. One thing that I think is really helpful is setting realistic expectations with mom about baby's going to breastfeed often. That's totally normal. Your early milk is called colostrum. There's not going to be lots of volume, but that's because your baby's stomach is small. I think those things are important. One thing I have found is that when women run into barriers, my personal experience has been that maybe there's a problem with latching or pain, or either the perception of low supply or a true supply or weight loss issue. And so hand expression can be a really valuable tool in mom's toolbox. I know we don't have a lot of time to teach that, but I think introducing it that tells mom that it's okay to touch her breasts and try to figure this out, because sometimes that's really uncomfortable if she's never done it before. And maybe just explain, you know, sometimes women have a hard time latching the baby, so learning to express some breast milk can help the baby to latch, and can also allow the baby to get some breast milk if we have any trouble. I a lot of times will recommend that they watch the YouTube video, or the Stanford University video on hand expression. You just type into Google Stanford University hand expression, it pops up. And I think it's a good idea to know about that ahead of time. Some women who are low risk with no history of preterm labor want to try it just to see. And if they're at 36 weeks, I think that's totally fine. She may or may not get any colostrum if she tries hand expression, but if she does, certainly she can save it and put it in a little syringe and put it in the freezer, and then she may have 2 or 3 teaspoons of colostrum to give her baby, and it helps her to feel ready. There's some resources that are available out there. Dr. Milk is a closed Facebook page, but it's also a website called drmilk.org, www.drmilk.org. It was started by a physician in Arizona as a social media support group for breastfeeding physician moms. It still is mostly that, but there are also some physicians who've joined who have an interest in breastfeeding medicine, and it's an opportunity and a forum to teach each other. The website, though, is open to everyone and is very helpful and has a lot of resources if there's things you're interested in as far as breastfeeding. So when I knew I was going to be giving this talk, I posed this question to the other Dr. Milk physicians and said, hey, what would you want to tell physicians about breastfeeding education in the office before a baby's born? One physician said, you know, she offers trimester-specific handouts that could be given at every visit, or just, you know, one per trimester, on the importance of breastfeeding, newborn breastfeeding norms, like the frequency of breastfeeding, going back to work, pumping, nipple pain, and finding a support system. One physician, I thought this was interesting, talked about all the downtime there is, like on labor and delivery, as someone comes in for triage and she thinks she's contracting, but she's only 28 weeks and really she's just being watched. That's a great time for them to do some reading and education. So if you can keep some handouts there at the hospital, they can be given to moms there. Personally, I think one of my biggest platforms that I feel like, where I feel like I can help my colleagues, is to really be sure we're giving accurate information to moms and be sure they know where to find it. It's safe to breastfeed a toddler or infant while pregnant. I remember being a 3rd-year resident telling a pregnant mom that she needed to wean her baby because she was pregnant. That was absolutely wrong, but no one had taught me any different. I know better now. But there's nothing wrong with that, unless there's, of course, high risk of preterm delivery. Another common problem is knowing which medications are safe with breastfeeding. So very few medications are contraindicated in breastfeeding. LactMed is a free app from the National Institutes of Health. And then Medications in Mother's Milk is a book that I think belongs in every single one of our offices. It's a really good detailed book that even talks about pharmacology and half-lives and really all the druggy stuff we learned in medical school and 3rd year med school. It goes through each one of those things and how it applies to breast milk. So how does this apply to our patients? We can tell our patients, hey, you can download LactMed or Mommy Meds, which is kind of the layperson's version, so that she's empowered a little bit, and just let her know, you know, if you're breastfeeding and a doctor gives you a medicine, please check with us if you're unsure or you're worried it may be unsafe. More often than not, doctors are telling patients they have to pump and dump or can't take a medicine when actually it's just fine. Quite honestly, even though I feel like we work in an office where we really strive to do a good job at this, I had a mom call me this weekend on call who was told that she could not take diflucan because she's breastfeeding a 15-month-old, and that's untrue. So we were able to kind of get that turned around for her. I think it's important we all understand that pumping and dumping is not benign. It should be the very, very, very last choice with a medicine that maybe there's no other alternative. Another common one is CT dye does not require pumping and dumping. A great resource if you're unsure and maybe it's a new medicine or a special situation and you'd like to talk to someone, the Infant Risk Center at Texas Tech University is available. Here's their number, 806-352-2519, or their website as well. You can get someone on the phone and talk with them. They have pharmacists available to actually, even if there haven't been studies, that they can actually figure out if the medicine will be in the milk or not. And that's a great resource too. If you don't know about it already, the Academy of Breastfeeding Medicine has, gosh, probably 20 protocols on all kinds of things, but one of them is a very detailed protocol on the breastfeeding friendly office. Again, you can take one step at a time. You don't have to do everything. Just asking a mom if she's considered breastfeeding goes so far, and that's all it takes. Taking out the marketing, getting rid of the free formula, that's a huge step. So each step on that protocol that you and your office or you choose to undertake is another step closer to, being a breastfeeding friendly office. And it certainly doesn't take everything. One step is great and closer than it was before. This is the internet address for the Stanford University videos. There are actually several. Hands-on pumping, evaluation of latch, hand expression, and you can show patients those videos or give her the website and she can look them up herself. Certainly you don't have to do that, but you can create a handout that has kellymom.com on it, has the times that your support groups meet in your particular community, has this website on it, has some books that you recommend on it, and you can just give her that. And there she has it all in her hands, and it took 10 seconds. So I was going to show you quickly, this is the Dr. Milk website. Can you see that? I don't know if you can see it or not, but this is the Dr. Milk website. There are a lot of resources on here, including documents.
We actually can't see it.
Oh, okay.
There you go.
Let me do this for you. Can you see it now?
Yes.
Okay. So this is the Dr. Milk website. It's drmilk.org. And if you go to documents up here, they have a lot of documents that are available for free. Caregiver's Guide to the Breastfed Baby, and talks about paced breastfeeding or paced bottle feeding. There's reverse pressure softening and how to get a baby to latch to engorged breast. Here's the guidelines for CT and MRI contrast from the ACR radiology group that says that you don't have to pump and dump if you have some pushback at your own hospital. So all of those things can be really helpful. There's some links here. So this up here is about supply. So there's so many resources out there. Academy of Breastfeeding is also great, but again, you don't want to get overwhelmed with there's too much to do. I think just knowing that asking the question and showing an interest and giving positive reinforcement can go so far. So that's what I got. Do we have any questions?
I do not see any questions at this time, but I invite people to take advantage of having Dr. Dornfield here and available to answer questions. But in the meantime, I have a question. I'm often asked as I'm out and about around the state what the role is of a practice physician when your local hospital is working towards becoming a baby-friendly hospital. Like what's expected, or how can the physician contribute to that? Could you address like what that meant to you in your practice?
Yeah, absolutely. I think sometimes there's this feeling of, oh my gosh, there's just more for me to do. You know, we all are feeling the pressure from, CMS, and there's all these boxes you have to click, and it's like, oh, it's another thing. This is an easy thing. It's simple. It's basically that we talk to women about breastfeeding and that it is evidence-based, that there's benefit to mom and baby, that we give her the education so she can make a decision herself, that we refer her to, we know where the support groups are and we can refer her to the support groups. We can refer her to a breastfeeding education class. We don't have to do it, but we don't have to do the education, but we need to be able to refer her for that. That we're not marketing formula because it's not evidence-based. That's basically it.
Mm-hmm.
We don't have to know everything and do everything, but we just have to be able to know where to send her and support her. So I think, taking away the marketing, another thing to think about is walk in your office from the front doors the way that your patients do, and think about, would my patient feel comfortable breastfeeding here? And there don't have to be any signs and things, but maybe there could be a little nook, or you could put a sign up that says, you're welcome to breastfeed here in our waiting room, or breastfeeding moms are always welcome in our waiting room, where we're happy to give you, a place of privacy if you prefer, something like that. Making sure that your front desk staff know your feelings about that, and that they are not going to, without you knowing, go up and tell a breastfeeding mom, oh, you shouldn't be doing that here. So just basic things. But to meet the baby-friendly guidelines, we need to recommend or ask about breastfeeding, recommend it using evidence-based evidence, refer to breastfeeding support groups and education. That's basically it.
Mm-hmm. I liked how you touched on sending people for care to board-certified lactation consultants, and that sometimes they're not reimbursed. And I think that Affordable Care Act does cover breastfeeding services, and so when IBCLCs can become licensed in the state, I really see this opening up a lot of opportunity for care within physician practices.
Absolutely.
But just to get on people's radar, there's only one state that just recently passed licensure, and that is Rhode Island. The other 49 states are working towards it. Our state is working towards it. And we know what this means for breastfeeding care. And we do have a licensure task force that is up and running, probably 3 or 4 months old. And if anybody has a desire to be part of that task force, they can certainly contact Indiana Perinatal Network. So just a little side note on that. And then let me see if we still do not have any questions. Do you have any closing thoughts that you might have come to mind just to provide closure?
Yeah. Well, I think it's an overwhelming topic to some of us, but it should be easy. Just like we recommend, that women take their prenatal vitamins and, get certain prenatal labs. It's just like, have you considered breastfeeding? And that sentence alone can really go a long way in encouraging someone to consider breastfeeding. I can't say enough about knowing where your support groups are, because those support groups can be really helpful. A lot of times there are IBCLCs in the support groups, or help manage the support groups, that can be a great resource to you and your patients. The Lactation League in my community has 3 or 4 certified lactation consultants that are willing to help women for free. So knowing those resources, you don't have to do it all. Just get them to the resources. I think is really important.
It's interesting because as I travel around the state, and I often ask questions when I get to talk with physicians, what's the top thing that comes to your mind of something we could give you to help you? And the answer across the board is updated resources. So I know, like, the updated numbers, everything updated. I don't care how you give it to me. so that I can access the care that exists in the community. And so one of the things I will say to people that might be part of a coalition, or they're part of a community looking to improve their access to care for breastfeeding, is make sure that the physicians in your community know where to refer out to, and keep that updated, and have it available. So it's hard if you don't have that resource to do that. So
in the social media, I think we can't discount it. We're a social media world now, so
yes,
that can be really helpful. There are some apps out there available for breastfeeding too.
Yes. Well, Becky, would you like to close out our training?
Sure. Okay. Can you see this last slide here?
Yes.
Okay. So as part of the CME offered for this particular webinar, an email will be going out shortly to those who have registered with this link in it, so you can complete that CME evaluation and the post test, and then you'll get your CME credit and certificates emailed to you within 2 to 4 weeks.
And I again want to thank very much Dr. Dornfield for your time and for helping us all, and appreciate it very much.
No problem. Happy to help anyway. And if there's anyone who wants to talk offline, I'm sure Tina or Becky can hook you up with my email, and happy to answer any questions.
Great. Thanks again. And